the Children's Committee of the Psychotherapy Action Network, and it's co-sponsored by the Chicago Psychoanalytic Institute and the Juvenile Protective Association. My name is Erika Schmidt, and I am the president of the Chicago Psychoanalytic Institute, a child, adolescent, and adult psychoanalyst, and a member of the PsiAN Children's Committee. I'm going to be the moderator for today's presentation. By way of introduction, let me begin by telling you a little bit about the Psychotherapy Action Network, which is nicknamed PsiAN. PsiAN is a free, all-volunteer organization with over 2,000 individual members who are mostly mental health clinicians, but also stakeholders, and 66 strategic partner organizations. Its mission is to protect and promote psychotherapies of depth, insight, and relationship within our professions, to the public, and to policymakers. Its aim is to restore these therapies to their fundamental place in the mental health landscape through education and advocacy regarding the personal, economic, and sociocultural effectiveness of therapy in alleviating suffering and transforming lives. The Psychotherapy Action Network was started by and is run by three phenomenal clinicians, Nancy Burke, Linda Michaels, and Janice Muir. Janice is our co-host today. Janice, do you want to wave hello?
Hi, welcome everyone.
Yes, and she's also the chair of the Children's Committee. The Children's Committee of PsiAN focuses on the population, obviously, of children and adolescents with the same mission: to promote therapies of depth, insight, and relationship, which are just as effective and as important for children and adolescents as they are for adults. The idea for this seminar grew out of conversations on the Children's Committee in the early days of the pandemic, when we were all acclimating to this strange new world and everything had been disrupted and upended. We were all trying to figure out how to cope with this suddenly changed way of living, and at the same time, we were so aware of the loss of all of our normal routines, our ways of being together with colleagues, patients, supervisees, as well as friends and families. Schools were all closed. Our schools where we educate and train, our trainees' schools where they learn the profession, and the schools that our children and adolescent patients attend. We still don't know when they will open again and under what conditions. So quickly, the weeks stretched into months, and now we find ourselves in the middle, unbelievably enough, of the fourth month of this pandemic. Many commentators have noted how the pandemic has brought into dramatic relief the systemic problems within our society, the social inequities, the economic inequities, and the health inequities. And then came the shock and the horror of the murder of George Floyd by a policeman in public. The protests that are continuing in the aftermath of his death are another dimension of the recognition of the need for social justice and systemic reform. Amidst all of this, we are continuing our professional lives in the context of disruption and loss. We're all learning to use distance technology and to try to maintain our therapeutic relationships and to provide continuity of care. Like many of you, I listened to a lot of webinars about teletherapy, and I came away very impressed with its possibilities and its potential for effectiveness. And yet it still challenges us to consider many questions when it comes to working with children and adolescents. How do we establish a therapeutic frame when using distance technology? How can we maintain and sustain these online relationships? How can we replicate or at least approximate the intimacy and the safety of our in-person offices? And how do the problems of poverty, working parents, close family quarters, lack of resources affect all of these efforts? And for our trainees, how can trainees continue to learn in the face of their truncated training experience and truncated therapeutic relationships? How can they integrate book and classroom learning with clinical experience when their clinical experience has been disrupted in this way? How can trainees navigate the greatly changed job market that they'll be facing? And what opportunities are there for self-care and growth in these times? These are the questions that bring us all together today. Before we begin, I just want to make a few questions about our format. Number one, as you all notice, this program is being recorded and will be available for anybody who wants it afterwards. So please refrain from recording it yourself, but it will be easily available. I want to also make a comment about confidentiality. The platform we're using today is not a HIPAA-compliant platform, and our presenters are only going to be presenting scanty clinical material without any identifying information. And anyone who raises questions or wants to discuss clinical material should be very attentive to the need to disguise anything that you say clinically. So thank you for that in advance. We have two presenters today. They're each going to speak for about 15 to 20 minutes. And then after that, we will have plenty of time for conversation and discussion and questions. I'm going to ask you, as you probably are by now familiar with, to use the chat box to send any questions that you'd like as the program is going on. You can send them right away. Janice is going to be collecting them and organizing them. And then we will, after the formal part of the program, get to as many of those questions as we possibly can. So with those preliminary comments, let me, with great pleasure, introduce our two speakers for today. Our first speaker is Nicole Tafero. Nicole is a clinical psychologist at the Advocate Children's Hospital Behavioral Health Services. It's a health system that serves the southwest and suburban areas of Chicago. As an affiliate of the National Child Traumatic Stress Network, Dr. Tefero's clinical interests and expertise center on helping underserved and minority populations cope with trauma. She also provides a great deal of supervision and training in the advocate system. Her talk is titled, and I made up this title, so she may want to refine it.
That's fine.
I'm calling it Disruptions in Learning and Therapy, Parallel Process and Reflective Practice. Nicole.
Thank you. Thank you so much for being here with us today. And I am going to get us started by just offering some foundational comments that are really centered on talking about the disruption of the training experience and also the disruption in the lives of the children and adolescents that we serve. And I want you to be thinking as I'm talking about the ways in which this has impacted you and your practice, and if there are questions or opportunities for you to share your experiences so that towards the end of our talk, we'll be able to engage in a fruitful discussion and be here to support one another as well. So, when thinking about what would be most helpful when having this webinar today, we came up with the word disruption in the experience. And I want to focus on the word disruption because how I have experienced this process and how I believe that families and clinical trainees alike have experienced this process is that there's been an interruption in the process of psychotherapy in addition to other areas of being. So for example, we talked a little bit about school and school being disrupted, not only for children that we're working with, but also for clinical trainees as well. And so really focusing and honing in on the word of interruption in the process, because I think that there's a lot of parallels that I would like to draw and bring your attention to if you have not already been thinking about this in this way for yourselves. So when I think about the parallels, I think about the clinical trainees experience and how the therapeutic frame and the therapeutic contract there has been an interruption to that process. the responses that the clinical trainee has had themselves as it relates to responses to COVID-19 and the responses to police brutality, structural and institutional racism, and how clinical trainees are managing the expectations that continue to persist within their careers and our clinical training programs. So in thinking about the clinical trainees experience, I then shift to thinking about the child and adolescent client as I think about the parallels. And also the child and adolescent client is dealing with the shift or interruption in the therapeutic frame and contract. They are also having their own set of experiences related to COVID-19 and in response to police brutality, structural or institutional racism. And as opposed to managing the expectations of their academic or clinical training programs, they are then managing the parental and academic expectations that they are faced with. So if I were to have just a comparison chart, they're very, you can draw the parallels very closely as it relates to the clinical trainees experience and in a broad way, and the child and adolescent client experience. So continuing on with the theme of the parallels to be drawn, when I think about the ways in which there is an individual response, right, to the interruption in the treatment process, for example, there is a role of systems and how systems interconnect in terms of how to support that process. So for the clinical trainee, I think about the role that their academic institution, your academic institution plays in helping to assist with the transition or the process of getting back on track, whatever that looks like. Also the role of the clinical training program that you're a part of and what that looks like. How does that program support ongoing treatment in the midst of a pandemic and social inequities and injustice? And then also, what is the role of the clinical supervisor as it relates to the trainee in the externship environment? And so similarly, the parallels for the child and adolescent client, as I've experienced it and my trainees have experienced it, the child and adolescent client has been faced with having to either get support or feel stressed by the role of their academic, their school, whether it's transitioning into electronic technology or having access to classes or keeping up with schoolwork. I also wonder about what is the role of the child or adolescent who is involved in the child welfare system and or the court system, and how that also influences how they are managing this time. And then the role of other systems that may be involved in the child's life if the child is currently in the juvenile justice system or other systems, if the child is in a detainment system, and how that is navigated during crises situations like this. And then also what the role is of the parent for the child and how they support or facilitate just maintaining the stressors involved in what we have all been experiencing. So some of the things that I want to be able to bring up as gentle reminders, because I've heard a lot of language and wording around the new normal and working remotely and so on and so forth. And one of the things that I think is important to keep in mind as a gentle reminder, and this is how I've kind of framed the disruption process, is that for clients, for children and for adolescents that I have been working with, helping to reframe when they're being told you are now homeschooling. And so this is not just about the fact that they're homeschooling, but what is actually happening, what their actual experience, as they've described it to me, is that they're attempting, and parents are attempting to educate their children during a pandemic, in the midst of social unrest. So it's more than just homeschooling, and that isn't necessarily an accurate description when you hear from them about what their lived experiences are. Similarly, for the clinical trainee and early career therapist and all of us who are clinicians, it's not as simply put as we're working from home. We're not just working from home, we're trying to work in the midst of a global pandemic and social unrest, which has a very different element of working from home. This isn't something that we necessarily had a choice to prepare and to transition into. Other gentle reminders are that we're not just social distancing at this time, but that we're trying to stay connected from a distance, and making that shift or adjustment as a gentle reminder. This isn't really about living in the new normal, but that we're continuing to exist in a time where nothing is normal. And that also thinking about self-care and remembering that we're not superheroes that are wearing capes that are going to, rescue our children and families from the situations that they're finding themselves in or that we're finding ourselves in, but that we're doing our best to be able to hold it together, and that is good enough, so to speak. And so those are gentle reminders that I like to keep in mind to kind of hold the frame as it relates to how to manage what we are all experiencing, with no necessarily pinpointed end in sight as it relates to timeline. And so, speaking within the parallel as well, I want to just kind of bring up some of what I have done in my own supervision sessions as it relates to how do I, as the supervisor, support the clinician so that they can support the family. Again, the parallel process theme. And so one thing that is discussed, or that I have discussed often, is what's called the oxygen mask theory, which is, I like to talk to the parents that I work with about this whole concept of taking care of yourself so that you can take care of your child. And I also use that analogy when working with supervisees around being able to first attend to what it is that I need so that I can sustain myself and be available to be able to sustain others. And so, one of the things that I focus quite a bit on in supervision and for clinical trainees is the importance of self-care and the importance of being able to help the caregiver for the children that we are serving take care of themselves and be reflective upon what it is that they feel like they're needing during times of unpredictable transition. And so some of what I've talked about in supervision and that I think is very helpful is gentle reminders to support self-care by creating supportive and reflective spaces to normalize and hold the trainee's experience. And the ways in which that is beneficial to the trainee also extends into the therapy room. And so one of the things that's important is, as much as trainees are given the opportunity to be able to talk about and share their own experiences and their own reactions to the disruptions that they have faced, or their own reactions to the social unrest that we're facing, then the better able they will be to have these conversations in the clinical space, even if the clinical space has changed from in-person to virtual. And so, again, being able to be there and having and creating brave spaces and safe spaces for the clinical trainee is going to be able to facilitate. It'll have a benefit of not only supporting the clinical trainee, but also benefiting the client as well, and being able to facilitate such discussions and holding such discussions with the child and the parent. For some clinical trainees, they have not had as much exposure to working with parents as they are now having, simply because the modality has changed, and perhaps the child was more involved in a traditional play therapy modality, and now with the shift in the treatment modality being through virtual, have had to have more contact, and are finding that there is strength in being able to support and hear from the parents about how they're doing, and how that trickles down into the parent being able to make meaning or create understanding of what the child's behavior is, or what the child's concerns are. Also, support that I think would be very helpful, and what I've seen to be beneficial, is really being able to name or speak the unspeakable as it relates to naming the cultural, political, and social factors that are at play, and creating an opportunity to be able to talk about these factors that are at play, both within the supervisory relationship one-on-one, but also at the system level, at a larger institutional level that students are a part of. And again, all of these recommendations or areas of support for students can also be easily transferred to ways of being with a child and their parent. And then finally, really being able to encourage more tangible coping skills or strategies around being able to take care of oneself, and sustainability in practice. And again, this can be implemented for teenagers, and also for parents who are taking care of young children, and their home life is now beginning to look drastically different, or there's particular stressors that are emerging that weren't emerging prior to. So how I talk about it with families, and also how I talk about it with trainees, is really breaking the day into thirds, in morning, afternoon, and evening rituals and routines. And this is a strategy technique that I have utilized with kids and adolescents, and have also found it helpful to provide support to my trainees. And I also use the practice as well. I often feel like if I'm not willing to try something, I shouldn't be recommending it. And so in terms of just promoting self-care, morning rituals such as mindfulness, meditation, music, exercise, just looking at my notes here, moment of gratitude, grounding, and just breaking the day in thirds, and putting in some self-care activities or practices or rituals and routines. And again, this is something that would be recommended for families as well. Some of what I'm talking about really has more than one benefit. One being able to just name what the experience is for the trainee, but also really being able to sustain practice over time. And when such skills are integrated in one's own practice, it does combat burnout, fatigue, secondary traumatic stress, and we're a vicarious traumatization, and we're all working, again, in the midst of a pandemic, in the midst of social unrest, not just working from home or not just responding to the new normal, but in highly stressful times. So it's very important to be attentive to how do you create spaces to be able to talk about how this is affecting you so that you can be present and available when working with children and families. And so I don't want to, belabor the point, but I wanted to bring up just, I guess, foundational principles around how the supervisor, how the training program can be of support to trainees, and how that can help to facilitate stability and safety and security in the clinical treatment process when there's been significant disruption. So I'll pause momentarily and shift over to my colleague, and then we'll go from there.
Okay, thank you very much, Nicole. I do want to just underline a couple of things that you said.
Yeah.
I was really struck by, and I want us to be thinking about. I so appreciate your saying that this is not a new normal. These are not normal times that we're living in, and I think we all really need to remember that and be able to not sort of get tricked into thinking, well, we're going to adapt and cope and somehow adjust to a really terrible, terrible situation that has laid bare some really systemic problems that we all live with. So I hope that we'll be able to talk more about that issue. And I think the other thing that you said that's so interesting to me is you didn't use the word nesting, but the way in which, all of our relationships are nested in other relationships.
Yes.
And to the extent that supervisors can help their trainees, the trainees can help the kids that they're working with, and
Yes.
and the parents can help the kids. And and PsiAN can help all
Absolutely.
of us. And I think that that's an important thing to remember. And I hope that that's going to be part of our new normal in
Absolutely
more significant ways than it has been. So thank you very much. And
You're
we'll
welcome.
get back to many of these points as we go on. Now it's my great pleasure to introduce to you our second speaker for today. Our second speaker is Karen Zilberstein. Karen is a social worker, and she is the clinical director of the Northampton, Massachusetts chapter of A Home Within. Some of you may know about A Home Within, but it is a national nonprofit organization that provides pro bono psychotherapy to individuals who've experienced foster care. Karen has also taught as an adjunct professor at Smith College School for Social Work for 12 years, where she also coordinated the child development team. She's authored numerous journal articles on various aspects of child therapy and parenting interventions, as well as an award-winning book called Parenting Under Pressure: Struggling to Raise Children in an Unequal America. Again, it speaks to some of our themes today. Karen's talk is titled Disruptions in the Therapeutic Process and What to Do About It. Karen.
Thank you very much. So I want to follow what Nicole's framing, which is very, very helpful, with a little bit more of the nitty-gritty about what are we going to do in our sessions and with our clients. When we face so many disruptions in our lives and in their lives, and the disruption to the therapeutic process. Teletherapy has been around for a long time, and there is actually a research base showing that it works well, but most of us had never trained on it. And I know that for me, 1 week I was doing in person, and by the following week, the governor here in Massachusetts ordered a shutdown, and the following week, all of a sudden I was doing teletherapy. So there wasn't even a lot of startup time for those of us who needed to pivot very, very quickly. So this is disruptive not only to us, but to our clients, as we've talked about. And there's a lot of disruptions, not just in the frame of therapy, but in how we do therapy and how well we can connect. And some of the structural inequities that we see in society also, we need to understand, do get replicated in therapy, including who has access to teletherapy and who has the right internet, how good is the signal. We can get disruptions replicated every time we do a session when internet connection fails, when the picture gets distorted, when the sound isn't good. Or even I work with a lot of people when they turn off the sound or turn off the camera or walk away, or so we have multiple disruptions every time we're doing therapy that we need to address. And I want to talk about that in a minute. But I also want to say that there are benefits and limitations to teletherapy. So for the most part, the studies have mostly been done on CBT, show that it's pretty much works as well as other types of therapy if you know how to do it. And that it can be that one benefit is that it can be more convenient for certain populations, especially people who had trouble traveling to the therapist's office, who didn't have money for gas, who had uneven schedules and couldn't make a weekly commitment. But again, we also have communities that don't have internet, where clients don't have privacy, and that there are time constraints on them. So we need to be very aware when we're setting up therapy about those structural problems and what to do about them. So I want to start from the very, very beginning and saying, to be successful doing teletherapy, one needs to be very aware of a family circumstance and what disruptions might occur there, or constraints, or what benefits there can be. And that just like when we have somebody in our office and we structure the therapy, we structure around a certain time and a certain place and a certain way of being, we need to set up that structure through teletherapy, and we need to do it in very explicit ways. So we need to be talking with the parents about their feelings about teletherapy, about whether they can make a dedicated space, whether privacy is available or is needed. And it may be that some people don't feel they need the therapy, whether there's a quiet space, whether there's certain tools that you need. For young kids, you're going to need to be playing with them over teletherapy. So working with the parents on putting that together. If parents are uncomfortable, and some are, or they don't have the platform, then again, it's talking through is the first step of therapy. Can you get internet connection? I know here in Massachusetts, we're a very progressive liberal state, and there have been a lot of efforts to get free internet to communities and people who couldn't afford it because they needed it for school and for others. So most people now in Massachusetts have some access to internet that they don't have to pay for. But if they don't, it's referring them to the application and the ways of getting that. And but a lot is also, are you comfortable with this? And how do I get people comfortable, and talking to them about it? And that means also, as therapy progresses, asking, how is this affecting you? What do you think of this? What's gained? What's lost? And bringing it in. So we're beginning, and this is one of the themes I want to make, is that whatever therapy you were doing before has been not just disrupted, but there's a lot of layers that's been put on it. And so we can't just continue to do therapy. If you were doing therapy for anxiety or depression, trauma, there's new issues that are now being come into the therapy that need to be attended to. And I know this is what I've gone to trainings about some of the evidence-based treatments who warn us against attending to the crisis of the day because you're going to get derailed. But I think in these circumstances, you need to be where the client is, and you need to attend to the crisis of the day. There's multiple crises of the days that we need to weave into our therapy and see how it's affecting both the client and the therapy. So one of them is, what is this platform like for you? What are the barriers? What are the benefits? There are some people who like it quite a lot. Privacy, again, can be an issue. I've had the really fascinating experience of a number of the kids I'm working with. We're video chatting, but the real therapy is happening through that chat button. And they are actually typing to me some of their biggest feelings. And it's not always because of privacy, but that is one way, if you need to structure some privacy in, is to say, type it to me. I think they're doing it in part because it's actually easier to type it than to say it. And some things have emerged that are much bigger. One child asked, am I psycho? I have urges to hurt people. And I'd been working with her. She'd never been so explicit about that before. She didn't say it to me. She typed it to me. So again, adjusting to this is thinking about what tools are at our disposal when we change modalities, and that's one, and how to use it and who to use it with. But I also think that we can't ignore in our therapy all of the other disruptions that have happened. And I think therapy in a time of pandemic and when communities are shut down, therapy is both a healing, curative, has that aspect, but it's also preventative, in that what we know is most important to people in times of pandemics is social supports. And there's numerous studies showing that people with social support fare much better than people who are in isolation. That's not just during pandemics, that's all the time, but that's been extended to previous pandemics. And so our ability to provide ongoing relationships and social supports is actually going to prevent further erosion of mental health issues. We know a few things. We know that during pandemics, PTSD, anxiety, and depression go up, especially PTSD if their lives have really been disrupted. We know that for people with pre-existing psychiatric conditions, it's likely to go up more. And we know that preventative interventions are likely to keep that at a lower rate. So we can't just ignore the preventative intervention that we're giving and the relationship and part of what keeps people from having too much anxiety and depression during a pandemic is whether they have the resources, whether they have financial resources, enough food. Right? During recessions and times of stress, we know that in families, maltreatment goes up, behavior problems of children go up, achievement goes down. So making sure that parents and families have the supports they need is also part of our preventative intervention. So I'm going to say that on top of whatever therapy was going on before, it's really important to be asking families, do you have enough food? Are you worried about income? What's happening with your job? Do you have worries about getting sick? Do you know people who have gotten sick? And in the social unrest that's happening, but even before, because the pandemic had started to show racism against Asian Americans, and now we've exploded in our understanding of racial inequality and structuralism. But are you experiencing racism? And I think we have to put these on the table for our clients. Without doing it, I don't think we are giving permission for them to come up. And I think this is a little bit controversial for some people with therapies, but if we're not asking, how is this affecting you? How are the protests affecting you? How is the violence affecting you? I asked one family that I worked with, how, after the George Floyd murder, how is this affecting you? And she said, you have no idea. My stepfather was murdered by the Ku Klux Klan. And that was a really important piece. How was she to be a parent and to hold what her child needed? And she was actually a foster parent holding a traumatized child, without being able to talk about this tremendous memory that had just been reawoken by the events. So we have to actually, and I don't think she would have brought that up to me because she was not my client. Her child is my client, right? And yet it's going to affect her ability to parent. and what, and it needs to be on the table for everybody. How are kids handling this? Often children do not make connections between their anxiety and what the cause is, but children are tremendously afraid of COVID. And if they're children of color, they're tremendously afraid of being scapegoated and hurt and killed, and it needs to be on the table. So on top of whatever therapy was happening before, I think we need to be at least asking and looking for it and listening for it, asking about worries and experiences outside of the presenting problem. When it does come up, we need to acknowledge the structural inequities and be upfront about that. We need to validate and support. And I think that if we don't, and again, I want to just emphasize, I think if we don't bring up these topics, we're giving the message that we're not interested and that it's not necessarily safe to bring. Especially, I think, when people have experienced racism, that how do they know that you're not going to be racist also, unless you're willing to talk about it with them? So I think I'm coming close to the end of my time, or maybe I have a little bit more.
Sure, go ahead.
I can go more?
Mm-hmm. Yes.
Okay. And we can talk more nitty gritty about how to bring play over the camera, but we can see what questions there are. I've been able to convert play therapy pretty successfully over video chat, which I hadn't expected to be able to do. With most clients, we've found a way of working, and I had one or two who were very hesitant at first until we found new ways of working. I'm lucky, I have a private office. I come into my office, I have all the toys that they did play with here. And sometimes my toys can say hi to them. But I've also, for some children, I've sent some toys to their house if they needed them, especially if there was a doll that they really needed to play with. One family that I work with who doesn't have a lot of money, they only had female dolls, and this child had an abuse history with a male figure, and they needed a male doll, so we got them a male doll. Again, that's part of setting up the structure, and we can talk more about that also, but I think that I want to reiterate and talk a little bit more about what Nicole mentioned, which is that therapists are also, for the most part, not completely the same, going through, this is a unique time in which therapists have faced disruptions in their life that's very similar to what our clients have. And I think that has to be acknowledged. We often try to be more of a blank slate, and we don't want to bring our clients into our problems, but they need to know if we're okay. They need to know that we understand what they're going through. I had a supervisor when I was first started who said, the more people don't have resources and good relationships and everything else in life, the more you have to be a real figure for them. There's always a question of how much do you disclose and what, and I'd say we have to be careful now, but I think this is a time that we also need to disclose a little bit about what's going on with us and if we're okay. People have learned a lot more about my family. My clients know a lot more about my family now than they ever did before, not because they need to know my problems, but because it's just so obvious that there's disruptions. So what happened to you and what happened? And actually that can be, because my children are older and okay, that can be reassuring. But it can be very hard for us to hold the same feelings when we feel really disrupted and really unsteady, to be able to hold those of our clients. Again, validation and support is one, but also where do we turn? We need to have places to ground ourselves and to work through our issues and our fears and our anxieties about what's going on if we're going to be able to listen to and hold the fears and anxieties of our clients. So I just wanted to reiterate, Nicole talked about that. I wanted to reiterate that. So I'll stop there, and I'm happy to get more into nitty-gritty if people have questions about that.
Okay, thank you very much, Karen. Again, I want to underscore a couple of things that you said that I think are really important. There's the "how are you" question, which I think we're usually accustomed to sort of thinking of that as a kind of social convention rather than as a real question. And in these times, I think we do much better if we treat it as a real question. How are you? Are you okay? I need to know that you're okay. I think that's really part of the process of creating a safe environment for a child or an adolescent or a parent to be able to talk. They need to know that you're okay, and to not be able to respond in some sort of direct way to that, I think really does a disservice to the experience. And so I think that that's really important. And the other thing is that I think that both Karen and Nicole really spoke to this in somewhat different ways, but the fact that we're living in the world that we're living in, and that the realities of social, economic, racial, health inequities are facing us every day and facing the people that we work with, whether they're, no matter who they are or where they live, people are being affected by this. And that if there's one thing that we think that well, I guess I'm speaking for myself, but I think I'm speaking more generally. What is therapy really about? It's about the freedom to think and the freedom to speak. And so when we talk about being able to bring up unspeakable topics, we're talking about the gift that therapy can be to people, no matter what it is that somebody considers unspeakable. And I think that unless the therapist is willing to indicate in whatever way they need to and whatever way their patient needs them to, that they're able to speak those theoretically unspeakable things, again, we're not really doing the kind of therapy that really is, I think, liberating for people, and that really enables them to live their lives more fully and more openly for themselves. So thank you both for bringing that message home loud and clear. And and the other thing that both of them have emphasized, again in somewhat different ways, is that you can't not talk about the inequities of the world around us. I think that it's such an interesting topic, and I think we're really going to learn a lot from it in this pandemic social unrest experience, because it really does us disservice for us not to think that these things have a huge impact on our subjective lives, on our internal worlds. And I just, a couple of weeks ago, was at the meeting of the American Psychoanalytic Association, and one of the emphases, one of the most compelling takeaways for me from that meeting was that one of the things that psychoanalysis has failed to do is that it has failed to theorize how social reality affects our psyches. And if there's one thing that we're going to learn from this pandemic, I think it may be how we might begin to do that. So thank you both. And I look forward to the questions and the comments and the observations that people have to make. So I'm going to raise questions and communicate the questions that have come across the chat. So here's the first question. How do we, as clinicians in training, best address disruptions in care for adolescents and children caused by, okay, so here's the question of the day, caused by systemic, I'm sorry, lost my place. Systemic issues such as racism and stereotypes that often plague people of color clients. For example, a bipolar person of color male presenting adolescent being diagnosed with obsessional disorder and medicated accordingly, even though their concerns and behaviors stem from constant racism and oppression. The mental health system has already applied a label which can disrupt their engagement and willingness to engage in support? As a trainee, what can I do to address the system causing these issues and disruptions? Thank you for the grand question of the day. I'll let both Nicole and Karen.
I want to just say that I think she said ODD, oppositional defiant disorder.
Oh, I'm sorry. I'm sorry. I just
Often what happens is that we know that males in particular, but people of color, are more likely to be diagnosed with a behavioral disorder than either a learning disability or trauma, and to miss the underlying issues that are going on. And we've become a much more trauma-informed society in our, and I shouldn't say society, a field, in that we think about trauma, but we still, our trauma checklist does not have racism on them as one of the traumas that people might have experienced. And racism is the same as a complex trauma. When it happens over and over again in large and small ways through big traumas and through microaggressions, the wear and tear is tremendous, and it's equal to any other trauma that's experienced. So I think the first thing, and I'll let Nicole weigh in a minute too, is that we need to let him know that that's not the view that the therapist is holding. And that there's an understanding that behavior is linked to experience, and that experience, what happened to him is what's most important. And that's, again, making it more trauma-informed. What happened to you, not what's wrong with you. So I want to know what happened to you, and I want to understand this, and I want to get to know you so that I can help advocate for you in these other settings. Because the medication might not be right. We certainly don't want the school or the mental health system to think of you, because this is how we start criminalizing behavior and sending young men of color into the criminal system instead of the mental health system. So that's where I would start, both talking with this child, this adolescent, and also I would be advocating for him. I would be asking to go to meetings and attend meetings. I do that all the time with families, where I can help them speak and speak for them if they want me to. You have to always be careful. You can't attend a meeting without permission. I'm very transparent about what I would say, what they would want me to say, when they would want me to step in or not. That's part of the discussion that we have before advocacy, that I would be on that front. I don't know if Nicole has something she wants to add.
I mean, I feel like your response was incredibly thorough. And in addition to what you're already discussing in terms of ways to help be an advocate and a voice for the client, is helping the client be able to identify for himself also how he understands his own symptoms, behaviors, emotions, and where they're originating from, and how to manage himself in a way that communicate a level of self-respect and assertiveness, and also being able to talk about what happens for that client when he does stand up for himself or assert himself or express himself. That the reality is, this particular client, I'm not, you said person of color, but there could be another potential risk to being able to be outspoken and assertive and advocating for himself. And so being able to work with the client around how the client and the therapist together can work on it seems like a tall order to shift the perspective or impression that others have of this client, but first starting within by helping the client to be more of a voice for his own treatment. And working with the parents. I'm not sure how old the client is, but for adolescents, being able to have more of a voice and role, as well as children, around medication as well.
And I just also want to add that when I suspect that there's been racism, you don't want to ever jump in with that accusation. It doesn't play very well, but also with the family. So I am more apt to say to the parents or the child, do you think that there racism may be going on here? Because it's really up to them, not me, to define it.
Right.
And so it's really, again, putting the questions on the table and inviting the conversation rather than jumping to a conclusion. And also and then there's, yes, that discussion about how are you going to, if they do think it's racism, how will it play and how do you address it? I wrote a letter recently where we suspected it, negotiated the wording with the family in which we said to the school, I know you share my concern that we don't pathologize young men of color, work hard to make sure that that doesn't happen in your setting, right? So rather than accuse, try to join. It's individual. How you do it.
Thank you both. We have now a series of questions. Actually, we're going to change the subject slightly from that to the intern experience. So let me tell you what these questions are, and they have to do with the disruptions for interns, which of course is sort of where we started today. First one is, I'm curious about people's thoughts about how to handle trainees feeling that they are missing out on key aspects of the clinical experience. For example, this past March, we were so quickly cut off from our school-based student clients. Our interns felt they didn't have the chance to experience termination, and now are going into their second year of grad school or the workforce without knowing what that feels like for the clinician. So that's one aspect of the question. Another variation on this is, do you have any advice for second year MSW students regarding remote learning and potentially disrupted internships starting in the fall? What can we do to better ourselves and strengthen our skills and knowledge as future social workers who might have to practice virtually? And then another question, are there resources for interns who will be doing telehealth for the first time that would help them engage with youth and children? Okay, so take it away.
I think just initially speaking to the disruption in the training process, you know, just normalizing and validating that, yes, that was very abrupt for many students and a loss in many students' training years. And so I would be curious about how the academic institution that they're a part of has held that, and if they have the opportunity to speak with their advisors and or institution around additional opportunities for training, if there's ongoing training that will be happening in the fall, if there's an opportunity to obtain some additional training called supplemental training in addition to current placements, if they felt that that would be helpful. So those are some of my initial thoughts. However, if graduating already, being able to become a part of a support network of clinicians, early career clinicians, who are able to kind of support one another. There are many different forums for that, to be able to provide ongoing support for one another, and joining various different organizations that offer support for ongoing training and development for early career mental health folks. I think there may be additional questions. Were there thoughts that you had, Karen? I'm trying to hold all of the questions in my mind.
I would say that one of the things that happened in this pandemic is that a lot of people have posted online and posted videos and training videos that you can access for free. So if you do some Google searches, you'll find some videos that people have put out about play therapy during telehealth. There's a Facebook group. about doing telehealth with children and play therapy with children, and you can get those resources. But to think creatively, I mean, it's an interesting situation we're in because the youth, and I'm looking at the question here about somebody who's transferring from children to late adolescent, young adults. Actually, our youth are more comfortable online than we are. They've grown up with it. They're the digital natives. There may be some people in this group who are also digital natives, but the digital natives are very comfortable online, and they're comfortable talking online. They've been doing this with their friends. They've been chatting. They've been using those modalities. I'm not having any trouble engaging teenagers and young adults online. They take to it really, really easily. And with kids, the trick has been finding ways to keep their attention, to keep them mostly in front of the camera where I can see them. So we'll be playing and the camera's not positioned right and I can't see, and I have to say, can you move that camera, or can you show me, or you? But most things that I've done in my office to convert to play therapy. So picture drawing, again, they have to have the same tools. I've played Uno, but they have to have a deck of cards and I have to have a deck of cards. Doll play, stuffed animals, you know, we bring them to the camera and we play out. And I have a 3.5-year-old client who has been able to play out her abuse, basically through dolls that she has on her side of the camera. She's pretty extraordinary to be able to do that at 3.5. But again, it's, can you structure, can you say, these are the tools I need to have here? Can you say, what do you have at your end? There's one client where we make a plan for the next session so that we both know that we have the tools that we need. You know, we're going to draw pictures, or we're going to play, you know, bring your dolls, bring your, so think most things you can do in front of a camera. It's been pretty fascinating to me. My stuffed animals can talk to their stuffed animals.
I want to add something to this conversation, in addition to, you know, what I think are some really important advice and tips that you've offered. But, you know, the reality is that this is a terrible loss for interns. And, you know, it's a loss for all of us in all different kinds of ways, but interns have a very particular kind of loss that they're experiencing in their, you know, right at the beginning of their careers, when they're ready and eager to learn, and suddenly the rug has been pulled out from under them. And the opportunity to sort of conduct therapy in the kind of unfolding way that we, you know, ideally would like to be able to do it, they're not having the opportunity to do, and they've been gypped out of some aspect of their training experience. That's just the reality. And I think, you know, we've all had our own losses in our own particular ways, but these are the losses for interns. And the loss of an opportunity to have a kind of termination experience, whatever that is, I think is, you know, that's a really, it's a difficult thing to learn. And when you sort of have to terminate before you can even talk about it, it really, you know, you don't have the opportunity to think about it. You don't have the opportunity to go and talk to your supervisor. You don't have the opportunity to think about what it brings up for you. And I think that that's a very, very difficult kind of situation to be in for an intern. And I think we have to recognize that this is the internship loss are of these kinds of opportunities. I think, as Nicole and Karen have both pointed out, there are many ways to compensate for those losses, and many ways to continue working pretty effectively and creatively. And, you know, I think it's really quite incredible to hear about the kinds of things that people have been able to do. But at the same time, it is a loss, and I think there's no way around that.
I agree. I think it's a huge loss, but I'm also disturbed to hear that internships would cut off and leave their interns in that position of not being able to terminate their placement, their work. It's not good for our clients to not have a termination. And as somebody who worked for foster children, where one of the prime experiences in life is loss after loss without a good termination experience, without goodbyes, being ripped from your home. This is really damaging, and we would never, in a home within, ever have a treatment end without a termination. Even if the client refused to come back, there would be a letter sent, there would be a follow-up, there would be some attempt to engage, to send a message from the therapist to help hold on to the value of the relationship. And I think that if internships haven't done that with their interns, there's been a huge loss and a huge blind spot in training that could have been avoided, because even with things disrupted, the institution had some obligation to do that.
Yeah, and an opportunity to think about the importance of termination and its impact. And I'm assuming that most places made some effort to do that, but I think even so, it is a loss. There is a question about transitioning from adolescence to young adulthood and from high school to college. Does anyone want to speak to that?
Sure. I mean, I can speak to it from the sense of I will often continue to work with the adolescents in the clinic that I'm in who are transitioning into their first year of college. I consider it to be often a vulnerable phase for them within their lifespan. I do like to utilize Erikson's psychosocial theory of development, assuming that the adolescent has already experienced mental health challenges. There's a lot of work that's done in order to help maintain stability in the first year and even beyond the first year. However, I'm aware with this particular question that it's the intern that's experiencing the shift in terms of moving from treating one population to the next. So the question becomes, with that particular setting, college counseling setting, are they working with what type of population that they're working with, and what are some of the particularities about the experiences that they are going to be encountering, because sometimes you have non-traditional students, sometimes you have international students, sometimes students, this is the first time that they're encountering mental health services or having a need for mental health services. Sometimes they're coming to counseling centers because it's been referred by a professor. Some learning disability has been diagnosed, or there's couples related, domestic violence related issues, or trauma. And so I do think that yes, there's an element of like extending adolescence through late adolescence, and then also late adolescence running through college years. And then also there's this component of it depends, I guess, would be the answer on in terms of what the client is actually bringing. But I do know that there's a lot of crisis management work that happens in college counseling centers as well. So I would say orientation should be taking place in the training setting. And within the orientation, I'm hearing that some orientations are taking place virtually. And so making sure that the questions that you have regarding shifting are being answered, and or you have resources that are provided to you about feeling more prepared to do the work.
Thank you.
Mm-hmm.
I think that, you know, for students entering college this year, there are so many uncertainties as well about
Mm-hmm.
what it's going to look like. I think there's a tremendous amount of anxiety about that. Okay, there's a question about some of the responses that you made earlier remind one of our questioners about the liberation model of health. And they're asking if that's a framework that you draw from, and whether you might have some other ideas about the practical applications of this.
Yeah.
I don't actually know what the liberation model of health is. That would need to be defined for me.
Yeah, and I did privately chat the individual to understand which one of our responses, Karen, they were referencing in terms of the liberation model. And yes, wanting to say also, this is a newer model that I'm hearing about. I've heard it the second time in 2 weeks now. So I'm also wondering how, if that is being taught in graduate school, and it's a newer model to me. So this is what I love about having these dialogues, is that I'm always learning something new. But someone's shaking their head, yes. Can you tell us?
If somebody, is there a way to raise your hand if you want me to unmute them so you can, or to, if somebody wants to be unmuted, type your name if you want to explain it in the chat, and I'll find you and unmute you. How's that?
Cool.
We can move forward, and then if somebody wants to.
Okay. All right. I have one quick question.
Have the answer. Or did you have something?
One quick question, and then there's one big question that I think is probably a good question to bring things together. But what happens when you're wearing a mask with a young child, somebody asks, and the way in which that is a barrier to building a connection, or how do you get around the mask?
Yeah, I'm finding this an interesting question in terms of our society and the ways that this pandemic is going to change a lot of things in our society. And young children are now going to be in a world in which masks, hopefully, for the next few months or so, are commonplace. So we don't actually know what their reaction is going to be and whether that just becomes their normal. I think like anything else you explore, you look for the reactions. If it's going to be in person, I don't know how much therapy is going to be in person because there's still a lot of risk there. And it seems to me that with play therapy, kids are touching everything. You know, it's even harder to sterilize your office after child therapy than it is after adult therapy. But I would want to get their reactions. I would want to show them, to look at how they're reacting. And I think there's ways that we can also desensitize children. So, and again, when you work with children with trauma histories, they actually have a lot of sensory issues. So how do we desensitize them when they have to wear a mask, but also to the changes in others? And there's ways to put the mask on a stuffed animal, to talk about it, to read books about it, to take it off for a second to show them who you are. I think you have to look at whether there's a fear reaction or curiosity, or what it is, and then to work around it. But I'm going to suspect that it's going to be more their normal than our normal. That they're going to adjust because they don't have the same model. For us, it's a bigger change to wear a mask than for a child who's young at this time and has less other experience.
Great. Nicole, do you want to add anything, or should I go on?
No, I was just intrigued by the definition of liberation health social work. It popped up in our chat.
Okay, do you want to comment on that, or?
To me, it sounds like a, I mean, I don't know all of the nuances, but to me, it sounds like culturally attentive and sensitive, attuned practice. So I'm going to be learning more about this.
Okay.
That's all. Thank you for sharing.
Yes.
Yeah, and I've just read it, and I think this is a really important comment and statement. I think that we've had very, very individualized, our theories of development and psychotherapy that we use are really based a lot on individualism. You know, what can the person do to become more resilient? How do you feel? How do you think? It's Western views of individualism. And even though we have the model of the person in the environment, which is really the social work mantra, it hasn't made it very well into psychotherapy. A little bit the environment, we think about the family environment. And when we think about the larger environment impacting them, we're looking at how it impacts their internal world. And I think this is really the next step in our theoretical understanding and growth in psychotherapy is, how do we not just understand the impact on the individual, but understand how we work with that impact, not just on, well, you have to be more resilient or you're anxious because of this, but what will happen? How do we change the culture and the environment when we know that there are structural inequities? There's going to be a reckoning in our own field now about the ways that we replicate structural inequities, and if there's other ways we do about, because some of the theories of resilience that we have really are asking the people who are struggling the most to be the most resilient.
Mm-hmm.
And it's not really fair. Mm-hmm. So we're going to have to be thinking more about how we leverage communities, because that is a source of resilience. So I think that practice is going to have to change more, and I'm going to have to read more about this liberation health, because I think it does fit into what I believe that we're going to have to do.
Mm-hmm.
More and more.
Thank you. I'm just going to add a comment. Somebody suggested that around the mask question, that people can wear a badge that has a photo of themselves so that you can see what the face really looks like. So that's an interesting idea. Here's I think a really important question from today, which is, moving forward, though no one really knows, what do you expect to see happening in the field? Do you expect telehealth to become the new norm? And will we see more of that and less of the traditional in-person therapy with children and adolescents? So I know none of us can predict the future, but let's think about that question.
Well, I'll start. I think it's not, I think it's going to grow, because we've been looking for years for ways to reach populations that have been hard to reach. In Alaska, it's really hard to get therapy and hard to get expert therapy. In lots of rural areas, you need to drive an hour for a therapist. And there have been already playing around with teletherapy as a way to do that, but not a lot of people signing on to do it. So I think it's going to expand, and it's going to expand in ways that are good to make quality therapy even more accessible. Because again, in some, we have therapy deserts where you don't have well-trained, qualified therapists working with populations. I mean, it's as unequal as our school systems in terms of who's resourced and who's not. So teletherapy holds some promise there. But in every study that I've looked at on teletherapy and how well it works, when you do the statistics, it's working just as well as in person. But most people, when they look at the qualitative interviews, say that they would prefer to be seen in person. And most therapists would prefer to work in person. So I think that when the in-person option comes back, most people will use it. But then there are the people, again, who can't afford the gas money or can't afford the childcare and have other constraints, this will open up and be used more by people who are finding the in-person hard. That's my prediction.
And I think just from the, many of the services are provided by insurance or covered by insurance, or many state insurances will allow for telehealth or the type of therapy that we're doing now. Some commercial insurances will continue and some will not. So there's a lot of advocacy in the area around how to get insurance companies to reimburse for the cost of services. So I do think that there's some more systemic barriers if individuals found this method or modality helpful. There may be some barriers that are beyond, like at a different system level.
Interesting, in Massachusetts, a bill was just introduced into the legislature to make it required that insurance companies from here on out cover telehealth.
That's awesome. That is awesome.
How is the pandemic going to change how we work and how we...
That's awesome.
It has made structural inequities more apparent to people. It's also made some of these other need for teletherapy more apparent also.
That's awesome.
You know, I think that one of the things that's also happened is that, you know what, necessity is the mother of invention, right?
Mm-hmm.
You know, within the mental health field, I think there's been a tremendous amount of resistance to using Zoom platforms or even telephone treatments. And I think that people having been forced to use it are now beginning to see what some of the possibilities of it are, and that it doesn't feel like such a sort of impossible hurdle to get over, and it rather is a different way of it's a different way of having access and being able to create a therapeutic situation with somebody. And so I think that there's a kind of resistance within the field that may, to some extent, drop away that we had seen before. And I think that that's important, and to me, it's a very interesting sort of social phenomena. You know, you know, the 80-year-old analysts at the Chicago Psychoanalytic Institute are now adept at using Zoom, and you know, never would have allowed themselves to even think such a, you know, horrible thing before. But people are learning, and I think it's really important to think about it as having both possibilities as well as difficulties with it. So, you know, it's frustrating to have a sort of film between you and the other person, but at the same time, you know, how would I ever, you know, how would a therapist ever talk to that person in Alaska otherwise? So I think I think it's really important. And I do think that this opens up a whole question of what is this field going to look like after this pandemic, or as we learn to live with this pandemic over the next couple of years. And I don't know.
So interns have that additional anxiety that the path may not be the same as it was, and the jobs may be different, and that's hard. On the other hand, they are getting hands-on training with everybody else in the same boat, and maybe one step ahead of the game with this experience, because they'll have experienced the way the profession is shifting. And that could be very, very helpful to them as well.
Mm-hmm. Yeah, I mean, you know, look at us today. We wouldn't have been able, you know, we have people here from around the country. We wouldn't have been able to do this otherwise, right?
Exactly.
So, Karen and Nicole, do you have some other thoughts about what things are going to look like going forward, or what you think would be most important as we have the last few minutes here?
I think I'm actually feel drawn to saying what I used to say to my students when I taught at Schmidt, and they were trying to incorporate all of this knowledge, and it was confusing, and how do you do it? What's wonderful about this field is that you never stop learning, and there's always more to learn. And it's a tough field, but you're always a beginner, even when you have experience. And I think it takes really about 10 years to feel that you have any sense of real competence, if you're going to be honest. It takes a lot of hours of work, seeing a lot of different types of clients, finding your own style of working. There is no one way to work. You develop your style, you develop what works in combination with what you learn. So there's going to be a lot of anxiety, especially in these times, but I think that process stays the same. And just be open to learning and growing and using whatever resources you can, and you'll get there. That's what I would say.
Nicole, do you want to add
Absolutely.
anything?
I would also say to stay connected to mentors, to faculty that you have developed and built relationships with, and to peers that will be your colleagues, and really making sure to create a circle of support for yourself. Because yes, we're always learning, and in terms of moving ahead, I think just in my own process, I'm anticipating that there's another cycle of concerns that may be coming forth and more prominent as we learn more about return to school with this particular population, as we learn more about potential second wave and flu season, and as either parents begin to experience more financial stressors and or health crises. And I know here in Chicago, there's a lot to be said about the ongoing community violence. And so just the layers on top of layers on top of layers, I think creates for a very busy time, particularly for mental health professionals. And so making sure to take the time to take care of yourself and to be able to sustain a practice that lasts a long time.
Yeah, thank you. I think the message here is that you're at the beginning of a lifelong process of learning, and I think thinking about it that way will be encouraging. And I think that Karen and Nicole are both right. You're always learning, and actually that's, I think, one of the great treasures of this career is that there's always more to learn.
Yes.
So, yeah. All right. Well, I want to thank everybody for being here with us today, for joining us on Zoom, and for participating in the Psychotherapy Action Network's first virtual seminar. We've learned a lot from you, and I hope that you've learned from us as well. So thank you. Thank you, Nicole, and thank you, Karen, for sharing your wisdom with us today.
You're welcome. It was a pleasure.
Thank you. Great being here with you all.
Yeah.